Alrighty, welcome this morning, and thank you very much for having all of us here. And then we're going to touch base briefly on a little controversy between PCI and a bypass in 2024.
All right, this is some of my disclosures, and I will, go ahead and present the case for you. See.
I have no disclosures. Alrighty, so we have a quick clinical vignette here. This is an 81-year-old male who's actually been very active all his life, but then during the last several months, he's complaining of worsening chest pain and worsening shortness of breath. This happens when he exerts himself. It's getting worse to the point that he's now starting to limit his physical activity. And given that he's been very active all his life, then he's actually getting worried to the point that he actually seeks attention. He's 81. He's got an extensive past medical history. He's got hypertension, hyperlipidemia, multiple stents. The last one was done in 2010. He's got some chronic kidney disease, sleep apnea. He uses a CPAP. But in spite of all that, he actually looks good. He's been a very healthy, young-looking 81-year-old person. He's been on good medical therapy. He's on DAPT with aspirin and clopidogrel. His blood pressure is controlled on losartan, amlodipine, and metoprolol. And he's been very stable, actually, until recently. So he went, this is the EKG that you can see right there. Nothing too crazy comes out of the screen. Looks fairly benign, rate is well controlled. He got an echocardiogram recently that showed a left ventricular ejection fraction essentially normal of 55-59%, a little of left ventricular hypertrophy, no major valvular issues, and of course some diastolic dysfunction there. Because of the symptoms, of course, he had a stress test that was reported as abnormal. He had a moderate to large size reversible defect in the inferolateral wall of the LV. Now, mind you, he's got stents in pretty much every artery. He's got stents in the LAD, RCA, and in the circumflex. So, of course, it's an inferolateral wall of the LV, so we're thinking maybe the circumflex, perhaps a large RCA that is providing this territory, but all in all seems to be the circumflex that is giving us some issues. All right, so what would be the next best step for this patient? Obviously, the next step will be medical therapy, optimization, and perhaps optimizing beta blockade, nitrates, ranolazine. But ultimately, because the symptoms are going and the abnormal stress test, he had a cardiac angiogram. And these are some of the images that we have there. This is the RCA, obviously, and you can see this is a diffusely diseased vessel. And you can see in the epicranial view on the right side of the screen, you can see the distal RCA, there's a lesion over there. It's good flow with a very large PLV branch going into the lateral wall of the LV. And this is the left system, and voila. So you can see here that the circumflex artery is completely occluded. There is a stent in the circumflex. That's the one that was done about 10 years ago, and is completely occluded. There's nothing in the lateral wall, and that probably correlates with the defect in the lateral wall in the stress test. And then you can see some faint collaterals that are going from left to left system there. But then on the LAD, you can see there's a ostial LAD lesion that looks pretty hazy. It's a good 70% lesion there. They did not show any significance on the PET stress test, but it's clearly very visible and looks very hazy there. So then here comes the questions. What could we do for this? I think I have another set of images. There. You can see how hazy the LAD looks in the proximal LAD. And the proximal LAD has diffuse plaques. There's even a mid-LAD lesion as well. But the circuit is completely gone. There's a stent there. It used to be a large OM branch, and it's completely gone at this point. So of course, he's on medical therapy, and then this patient, we calculated his syntax score, syntax 1 score, and he's a perfect 22.5 that is specifically tailored for this talk. So the question is, someone like this, what would be the next best step? Should we do this, continue medical therapy and focus on the ischemia trial, for example? Should we send it to bypass? Or should we do PCI, and if that, from where? Dr. Orozco, what do you think?
Well, first and foremost, I want to thank you, Texas Heart, for the invitation to have this nice discussion about this controversy. And I just want to let the audience know that here at Texas Heart, cardiologists and heart surgeons, we are pretty much do what is best for the patient. There is no competition in what is best, PCI or coronary bypass. I think we always advocate for what is best for the patient. But I want to tell you my personal opinion about this particular case, and you can give me this forward here. All right, so this classic paper about the Cleveland Clinic flow loop, and this is not my personal quote, but Robert Guyton quotes and says, like, if I have coronary disease, give me a good limit to my LAD, and you can do whatever you want with all the vessels. And it comes from the fact that, the internal mammary, the survival at 10 years in 3 vessels, in patients with 3 vessel coronary artery disease is better than all these people who got saphenous vein grafts at 10 years, which is very important. And also, what happened at 10 years in those patients that you add and have normal left ventricular function, middle impairment of the ventricle, the survival at 10 years is great. But what happened with those people who has a moderate to severe low ejection fraction and you did not add LAD to the operation, really the survival decreased at 10 years. So I think it proves a point that the LAD works. And fundamentally, the PCI and CABGs, they're very different. They all work, but they're very different. And as you can see in these slides, what it says, the PCI treats an isolated flow limiting lesion in the proximal vessels, which is, for this particular case, it can work. But on the other hand, the CABG bypasses this lesion and protects against lesions that can, this artery can embolize. As we know, all these lesions happens pretty much in the proximal part of the artery, which is the case of this patient. So provides also unlimited and alternative blood flow to this, protects effectively against STEMI, and also the biology of the graft provides surgical arterialization. Yeah, so I think for this particular case, I think a limit to LAD, the guy's in good shape, I think it would be reasonable. I don't want to talk about bad about stents, but there's more work about that, that when you put a stent, also you can develop some, this is experimental animal work, but the more and more we know about this is that these stents, they tend to create some inflammation distal to the lesion that you're trying to achieve, and this doesn't happen with our arterial conduit. We know that CABG is better than optimal medical therapy, as you mentioned, in this all meta-analysis by Yusuf, and in terms saying that CABG surpass optimal medical therapy at 10 years. The death at 10 years, 50% of those people who just got optimal medical therapy. We know that in 1994, probably the optimal medical therapy is not the medical therapy that we know right now. So probably, we can take that in consideration. But what about if PCI is better than optimal medical therapy? We have tons of trials about this, and PCI is no better than optimal medical therapy, is the reality of things. And as you can see, there's different trials, and what really works in optimal medical therapy with PCI is that he has angina relief, which this patient has. So I think the benefit of doing PCI is more for the fact that the guy is going to have some angina relief with this. And what about PCI? Is better than coronary artery bypass? Well, we have different trials. We have the Freedom trial, the Excel trial, and there is a little bit advantage of CABG with PCI in that at 5 years, as you can see in this nicely graphic that I'm pointing out here. So you mentioned about the Ischemia trial. The Ischemia trial is this elegant study, very recent study for 2 years ago, I believe, in which those patients that were randomized to an invasive strategy and optimal medical therapy or catheterization or optimal revascularization, it means CABG, or a conservative strategy, which is the best medical therapy. Granted, these are these patients that were pretty much normal patients with normal ejection fraction with moderate to severe ischemia. And I want to point that, the major exclusion criteria, as you can see here, is pretty much all those patients that we're getting for CABG right now. So I think the ischemia trial for many of these patients, we have to take consideration what were the exclusion criteria for this particular trial and make sure that, we don't fall in the category that, put on the ischemia trial path because it won't be probably appropriate for this. So what the ischemia trial limitations, I think, just in considerations, it didn't apply for patients with left main disease, patients with lower ejection fraction around less than 35%, which is an indication right now, I think, class 1 to do a coronary artery bypass. The CABG was under-utilized in the trial, around 20% of all these patients. 40% of the patients were diabetic, and we know that the CABG works in diabetic patients. And the optimal medical therapy was only achieved in 40% of patients. Why? Because it's very, very hard for patients to keep taking medication for a long time. So, we have the guidance that, they come in 2021 about the revascularization. And, I'm going to mention that for the patients or the people in the audience, what we do in these operations, why we're doing a revascularization is, one, to improve survival, to prevent cardiovascular events, so to improve quality of life, in this case, angina. But in the 2021, something happened about including the ischemia trial and downgrading the recommendations for CABGs. In this case, we know that CABG works in all those patients with EF for less than 35%, but what about in those patients with EF of 35 to 50%? So actually the ischemia trial, or the data, was used to downgrade the recommendations for CABG to class 1 to 2A. And what about in those patients with normal EF and three-vessel disease? Also, downgrade the recommendation for PCI and CABG to 2B and 2B. So, as we know, we as surgeons, we like to, create some controversy, and then we create this, that we are not endorsing the 2021 recommendation for guidance based on or what the data was used from the ischemia trial. So does it change my practice? I think yes, in terms of that, the medical therapy should be in every single patient. Optimal medical therapy makes the results of CABG better, and I think CABG provides the most durable and safer operation. And also, we are coming with data more and more that a second arteriograph can add into this. So I'm not going to read over this slide, but it's just PCI and CABG. They are complementary procedures. And if you ask me a question again about this patient, I think a Lima to LED for this patient, it would be the best option. And I will open the discussion for you, Jorge.